Hello, everyone. Welcome to PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Lina, and joining me today is none other than Alzahraa. Together, we're taking you through one of the most foundational topics in pathology. Are you ready for it? Lymph node disorders and lymphomas.
Hi, Lina. I'm excited for this one. Lymph nodes may be tiny, but once you understand how they're built and how they react, suddenly all the disease patterns and lymphoma classifications make sense.
Exactly. And that's why we're starting from the very beginning of the story what normal lymphoid tissue looks like. Because once you see how beautifully organized it is, every abnormal change becomes much easier to recognize. Alright, so let's picture a normal lymph node. You've probably felt them before. Those small bean shaped structures along lymphatic vessels. Normally, they're under a centimeter and quietly doing surveillance work in the background.
And they're everywhere. We have lymph nodes, tonsils, adenoids forming Walder's ring, Pierce patches in the ileum, the appendix, and even the white pulp of the spleen, all part of the body's immune network.
Before we zoom into the lymph node itself, it helps to remember that lymphoid tissue is divided into two major compartments central and peripheral.
You're right, Lina. The central lymphoid tissues are the bone marrow and thymus. That's where the lymphocytes first develop. This is all antigen independent. They mature there before ever seeing any foreign intruder.
And once they're fully trained, they head out to the peripheral lymphoid organs the lymph nodes, spleen, and all the malls we just mentioned. These are the places where they actually meet antigens and mount immune responses. So now let's walk into a lymph node. Figuratively, of course. It's organized into three main areas the cortex, the paracortex, and the medulla.
The cortex is the outermost layer, and this is mainly the B cell zone. Here, you find two kinds of follicles primary and secondary follicles. Primary follicles are basically resting collections of small B cells. They're quiet, no germinal center. Secondary follicles are active. They develop germinal centers when B cells are actually responding to antigen.
And those germinal centers are busy places, just like a facial food court on a Sunday afternoon. This is where B cells proliferate, undergo class switching, and eventually become plasma cells or memory cells.
And right below the cortex, you hit the paracortex, which is dominated by T cells. This area also has postcapillary venules, which are the gateways where lymphocytes leave the blood and enter the lymph node, ready to face the world.
And then everything drains towards the center, the medulla. You have medullary cords and medullary sinuses, which act like the final checkpoints before a lymph exits the node. So, before we move on, I want to connect this to why we even care. How does knowing this normal architecture help us understand disease?
It helps a lot, actually. When B cells are being stimulated, you literally see the follicles expand. That's follicular hyperplasia. If it's mainly T cell activation, the pericortex becomes enlarged. And when macrophages are the dominant responders, the sinuses widen. So each reaction pattern is tied directly to a zone of the lymph node.
And when we eventually talk about lymphomas, you'll see how malignant cells often take over specific areas too. So, this map is the key to decoding everything that comes next. Now that we have a solid picture of how a normal lymph node is organized, let's talk about what happens when things go wrong, specifically lymphadenopathy. This is something clinicians see all the time, and the challenge is figuring out whether it's something benign or something that needs serious attention.
Exactly. Lymphadenopathy simply means enlarged lymph nodes, and that enlargement can be either localized, like from a nearby infection, or generalized, which we usually see in systemic diseases.
And age actually gives a lot of clues. In patients younger than 30, most enlarged nodes are benign, around 80% of cases, in fact. But in older adults, especially 30 or 40, the chances of malignancy increase.
Right, but it's not a perfect rule. Kids can still have malignant lymphadenopathy, but statistically, younger patients lean toward reactive or infectious causes, while older adults lean toward neoplastic ones.
Okay, so let's say a patient comes in with a big lymph node. What's the workup like?
First, always start with a good clinical history. Then, blood work, serology when needed, maybe imaging if something feels off. And if the picture still isn't clear, you can do fine needle aspiration or a biopsy.
Hmm. A biopsy, you say? The gold standard is really a full excisional biopsy, right?
It sure is. Fine needle aspiration is useful because it's quick and minimally invasive, but it only gives you individual cells. An excisional biopsy, on the other hand, gives the entire architecture cortex, pericortex, medulla, and that's crucial for diagnosis.
All right, now let's get into the types of reactive lymphadenitis because I feel like this is where students often get lost. All these terms like follicular hyperplasia and sinus histiocytosis, what are even those?
I agree, but once you know the normal structure, these patterns feel totally logical. Let's start with the simplest one acute nonspecific lymphadenitis. This is just acute inflammation of the lymph node, usually due to a pyogenic organism.
So, this is like when you have a local skin infection and the lymph node that drains that area suddenly becomes big and really tender.
Yes, and histologically, you'd see a strong neutrophilic infiltrate. In severe cases, that can become so intense that it forms an abscess, and clinically, those nodes feel fluctuant.
And then we move into chronic nonspecific lymphadenitis, which has different patterns depending on which part of the node reacts.
Precisely. If the follicles are the main site of activity, that's follicular hyperplasia, a B cell response. If the pericortex is expanding, that's pericortical hyperplasia, a T cell response. And if the sinuses are enlarged, that's sinus histiocytosis. And you guessed it, a macrophage response.
Have you noticed how each pattern matches the zone's job? I really like that. B cells in follicles, T cells in pericortex, macrophages in sinuses. It's almost like, picture this, the node is raising its hand and telling you what kind of immune response is happening.
Then we have the granulomatous lymphadenitis, which is important because it has many causes TB, atypical mycobacteria, cat scratch disease, fungal infections, sarcoidosis, and more.
And these nodes should always be cultured, right? Because the appearance of a granuloma alone doesn't tell you the cause.
Absolutely. You look at the presence of necrosis, the type of giant cells, the granuloma distribution. All those tiny details help point toward the right diagnosis.
Alright, let's briefly recap this section before we move on. Lymphadenopathy can be benign or malignant, depending on age and clinical context, and reactive patterns follow the part of the node that's being stimulated follicles, pericortex, or sinuses.
Uh huh. And now that we've covered the broad categories, we can go deeper into the specific disorders, the ones with the very distinct clinical pictures.
Let's start with a classic. A 17-year-old comes in with a really sore throat, fever, and just looks exhausted. When you examine them, the cervical lymph nodes are big and tender, and their spleen feels enlarged. Straight away, the likely culprit becomes obvious for most of us.
If you're thinking of infectious mononucleosis, you are right, especially at that age. Infectious mononucleosis is a self limited viral illness caused by Epstein Barr virus, or EBV. It mainly affects adolescents and young adults, and once you've seen the presentation a few times, you won't forget it.
What I find helpful is that the symptoms kind of line up in a neat package fever, sore throat, generalized lymphadenopathy, and often hepatosplenomegaly.
And when you check their peripheral blood smear, you'll see atypical lymphocytosis. These are reactive CD8 positive T cells, not abnormal B cells. The cells look big and irregular, almost confusingly malignant looking, which is why clinicians should avoid biopsies in typical mono cases.
Right, because the lymph node can look bizarre under the microscope, even similar to Hodgkin or non-Hodgkin lymphoma, and that can lead to a completely unnecessary misdiagnosis.
So instead, we rely on serology. Historically, the monospot test was used to detect heterophile antibodies, but it's as reliable as seeing a mirage in a desert. Basically, not very reliable. Nowadays, we look at EBV specific antibodies.
Like VCA-IgM, VCA-IgG, EA, and EBNA. These are a lot of letters, each with its timing pattern.
Exactly. VCA IgM appears early and disappears within 4 weeks. VCA IgG lasts for life. And EBNA shows up after about 4 weeks. That pattern tells you whether it's a new infection or a past one.
So, how do we treat it?
Supportive care. It's self-limited, so rest, hydration, and analgesics will do. And please avoid contact sports because of splenic rupture risk.
Quick question for our listeners. Yes, you. Did I catch you off guard? Think of this. In a teenager with fever, sore throat, cervical lymphadenopathy, and atypical lymphocytes, what's the first investigation you should order?
EBV serology, not a biopsy, and not the monospot as your main test. Remember the mirage in the desert?
All right, next case. Let's see if you can catch this one. A 10-year-old boy comes in with swelling in his axilla. His mother casually mentions they just adopted a playful kitten. Adorable, but a little risky. He also has a small crusted scratch on his hand from a few days ago. Ouch.
That's a given. It's a classic cat scratch disease. It's a self-limited infection caused by Bartonella hensleyi, a bacterium carried by kittens. No matter how innocent looking, it spreads through flea bites on the cat, then to humans through cat scratches.
So the first thing you see is that papule at the scratch site, right?
Yes, a small red papule appears 7 to 12 days after the scratch. Then, regional lymphadenopathy develops, especially in the axillary or cervical nodes.
The good news is, most of the time, it clears up on its own.
They do, but erythromycin can be given in more symptomatic cases.
Love it. All right, listeners, time to get these brain cells to work with a quick MCQ. A teenager with a kitten at home develops tender axillary lymphadenopathy after a scratch. Which organism is most likely responsible? A. Toxoplasma gondii, B. Bartonella hensleyi, C. Francisella tularensis, or D. Yersinia pestis?
Correct answer is B. Bartonella hensleyi.
Here is another cat case for you, cat lovers. Our next patient is a 23-year-old woman with mild fever and swollen posterior cervical lymph nodes. Her history? Well, she has a pet cat and admits she's been cleaning its litter box recently.
Oh, those posterior cervical nodes always make clinicians pause. But in young women with cat exposure, think toxoplasmosis. This is an infection by Toxoplasma gondii, an obligate intracellular parasite. Humans get it from cat feces or undercooked meat.
But some people are asymptomatic, right?
Yes, but others develop lymphadenitis, especially posterior cervical. On biopsy, you see florid reactive follicular hyperplasia with clusters of epithelioid histiocytes called microgranulomas.
And we always worry about toxoplasmosis during pregnancy.
Oh, definitely. Congenital infection can cause severe fetal damage.
Here's a quick question for you. Let's see if you have been paying attention. What biopsy feature suggests toxoplasmosis in lymph nodes? A. Caseating granulomas with Langhans giant cells. B. Diffuse neutrophilic infiltration. C. Clusters of epithelioid histiocytes. Or D. Sinus histiocytosis without granulomas.
That should be C. Clusters of epithelioid histiocytes.
Okay, enough cats for now. Let's talk about a condition that surprises a lot of clinicians. Imagine a young woman in her 20s presenting with tender cervical lymphadenopathy and fever. No infection signs, no autoimmune history, and her nodes look quite alarming.
This could very well be Kikuchi's disease, also known as histiocytic necrotizing lymphadenitis. It's a self-limited autoimmune-like condition that was initially described in Japan, but we see it globally now. It's especially common in young women.
What throws people off is how necrotic it can look, right?
Yes, it shows necrotizing granulomatous inflammation, but here's the twist. No neutrophils, very few or absent plasma cells, and lots of atypical lymphocytes. These features can mimic malignant lymphoma, which makes it so tricky.
Well, you know I like asking questions.
That's alright, Lina. Bring it on.
In Kikuchi's disease, which inflammatory cell type is notably absent?
None other than neutrophils.
Let's move on to our final disorder in this group. A patient with known HIV presents with generalized lymphadenopathy. Depending on the stage, the picture can be very different.
Exactly. In early HIV, lymph nodes show florid reactive hyperplasia. The immune system is highly active. But in late stage disease, after CD4 T cell depletion, the nodes become atrophic.
And HIV patients can develop both infectious and neoplastic causes of lymphadenopathy.
Right. Infections like TB and fungal diseases, and neoplastic processes like Kaposi sarcoma and lymphomas. Kaposi sarcoma can even involve the lymph nodes themselves.
So, in this entire group, mono, cat scratch disease, toxoplasmosis, Kikuchi's disease, and HIV, the key is recognizing the unique patterns, age groups, exposures, cell types, and clinical clues.
Yep. And now that we've covered the non malignant causes, we are ready to move into the malignant side lymphomas.
Alright, everyone, now we're officially stepping into the malignant lymphoid disorders, starting with Hodgkin lymphoma. This one is actually really unique, both in how it looks under the microscope and how it behaves clinically.
That's true. The hallmark of Hodgkin lymphoma is the Reed Sternberg cell. These are large, binucleated cells with prominent nuclei, the classic owl's eye appearance. What's interesting is that these malignant cells make up only a small fraction of the tumor. Most of what you see is actually the reactive background they attract.
And clinically, patients usually present with painless lymphadenopathy, emphasis on painless, especially in the cervical region. Some may also have the well known B symptoms fever, night sweats, weight loss, but the subtypes each have their own fingerprint.
They do. So let's walk through them one by one, because each subtype has a distinct look and clinical behavior.
Let's start with the most common one. Picture a young adult, most often a woman, who comes in with a painless cervical lymph node and maybe even a mediastinal mass on imaging.
That's classic for nodular sclerosis Hodgkin lymphoma. Under the microscope, you'll see broad collagen bands, dividing the lymph node into nodules. And the Reed Sternberg cells here are typically the lacunar variant, which looked like they're floating in empty spaces.
And this subtype really loves the mediastinum. You'll see it pop up there pretty often. Now, moving on to a completely different picture mixed cellularity. These patients usually present with more advanced disease, and the background is much more chaotic.
As the name suggests, it's a mix of everything eosinophils, plasma cells, histiocytes, all surrounding the Reed Sternberg cells. This subtype also has a strong association with EBV infection, which is an important clue.
And unlike nodular sclerosis, this one affects a wider age range and often comes with systemic symptoms. Next is lymphocyte rich Hodgkin lymphoma. The presentation tends to be at an earlier stage, and the nodal involvement is more peripheral.
Yes, and histologically, the background is dominated by small lymphocytes, with only scattered Reed Sternberg cells. It's actually considered one of the best prognosis subtypes.
And then we have the opposite end of the spectrum lymphocyte depleted Hodgkin lymphoma.
This one is rare, but aggressive. You see numerous Reed Sternberg cells and a scarcity of lymphocytes. It's more common in older adults, HIV positive patients, and those with EBV infection. Because the reactive background is missing, the disease tends to behave more aggressively.
And lastly, we have a subtype that isn't part of the quote unquote classical group nodular lymphocyte predominance.
Yes, this one stands apart. The malignant cells are LNH cells, or popcorn cells, and they're CD20 positive, unlike classical Reed Sternberg cells, which are CD15 and CD30 positive. Clinically, patients often present with localized peripheral lymphadenopathy and have an excellent prognosis.
So, overall, Hodgkin lymphoma really does come in flavors nodular sclerosis, mixed cellularity, lymphocyte rich, lymphocyte depleted, and the nodular lymphocyte predominance type. Each has its own architecture, association, and clinical behavior.
But once you know those patterns, identifying the subtype becomes so much easier. The background infiltrate, the type of RS cell, the presence or absence of fibrosis, everything tells a piece of the story.
Okay, you already know what time it is. Let's do a quick review with some questions before we dive into non-Hodgkin lymphomas.
Here we go.
Okay, first question. Which subtype of Hodgkin lymphoma is the most common and often presents with mediastinal involvement? A. Mixed cellularity, B. Nodular sclerosis, C. Lymphocyte rich, or D. Lymphocyte depleted?
The answer could only be B, nodular sclerosis.
Alright, next one. Which subtype is strongly associated with Epstein-Barr virus and has a polymorphous background with numerous inflammatory cells? A. Nodular lymphocyte predominance, B. Lymphocyte rich, C. Mixed cellularity, or D. Nodular sclerosis?
That would be C, mixed cellularity.
Let's see if you can catch this one. Which subtype shows popcorn cells and is characteristically CD20 positive? A. Nodular lymphocyte predominance, B. Lymphocyte depleted, C. Mixed cellularity, or D. Lymphocyte rich?
Popcorn cells that are CD20 positive, that is A, nodular lymphocyte predominance.
Alright, brace yourselves for the last one. Which subtype is the least common, presents aggressively, and is often seen in older adults or patients with HIV? A. Lymphocyte depleted, B. Nodular sclerosis, C. Mixed cellularity, or D. Lymphocyte rich?
That one is A, lymphocyte depleted.
Alright, now we move into the world of non-Hodgkin lymphomas, which is honestly much more diverse than Hodgkin lymphoma. Hodgkin has a handful of well-defined subtypes, but NHL is a whole universe.
Oh, they are. NHLs vary in cell of origin, aggressiveness, clinical behavior, and even where they show up. Lymph nodes, extranodal sites, GI tract, skin, literally anywhere. And most of them originate from B cells, but we also have T cell and NK cell lymphomas.
So the best way to approach them is subtype by subtype, and we'll start with the small B cell lymphomas. Let's begin with small lymphocytic lymphoma, SLL, and chronic lymphocytic leukemia, CLL. These two are basically the same disease, just differing in where the malignant cells show up. Is that right, Zahra?
Exactly, but it's really self explanatory. CLL is when the abnormal small B cells are predominantly in the blood. SLL is when they're primarily in the lymph nodes, but biologically, they're the same entity.
Clinically, they're indolent, more common in older adults, painless lymphadenopathy, maybe splenomegaly.
And don't forget the smudge cells on blood smear, a classic CLL clue. In lymph nodes, you see proliferation centers, also called pseudofollicles, which are small areas where the tumor cells are slightly larger and more active.
Now, jumping to a very different energy. Diffuse large B cell lymphoma. This is fast growing and aggressive.
Yes, DLBCL is the most common type of NHL overall. The cells are large with prominent nuclei, and they form sheets. They basically wipe out the node's normal architecture. Clinically, it can arise in nodes or extranodal sites, GI tract, liver, spleen, you name it.
And even though it's aggressive, it's also one of the more curable lymphomas with appropriate chemotherapy. Sounds paradoxical, right? Next up, follicular lymphoma, one of the most important indolent lymphomas.
Yes, and a very common one. Follicular lymphoma comes from B cells and forms back to back follicles that do not respect normal nodal architecture. It's strongly associated with the T1418 translocation, which leads to overexpression of BCL2, an anti apoptotic protein.
Oh, so that's why those follicles survive longer than they should. They basically refuse to die.
Exactly. Clinically, it's indolent but not curable. And over time, it can transform into DLBCL, which is more aggressive.
Now, switching to something very aggressive, Burkitt lymphoma.
Burkitt lymphoma is one of the fastest growing human tumors. It's associated with c-Myc overexpression due to translocations like T814. There are three main forms: endemic, African, sporadic, and immunodeficiency associated. The endemic form is most commonly seen in the mandible, or jaw and abdomen. Try to remember it by saying, my mic is swollen, because mic sounds like neck.
And morphologically, you see the classic starry sky pattern. Do not confuse it with starry night. Very Van Gogh, but it is not.
Yep, the tumor cells die rapidly, and macrophages eating them create the lighter colored stars. It's very characteristic.
Mantle cell lymphoma is another important one.
It's an aggressive B cell lymphoma characterized by the T1114 translocation, leading to overexpression of cyclin D1. This protein pushes cells into the cell cycle so they proliferate uncontrollably.
And it often presents late, right?
Yes, patients may have generalized lymphadenopathy, bone marrow involvement, or GI tract involvement like lymphomatous polyposis.
Now, let's talk about marginal zone lymphomas, especially the extranodal ones, MALT lymphomas.
These arise from post-germinal center, memory B cells, in the marginal zone. They often develop in chronic inflammatory settings. Think H. pylori infection in the stomach, Hashimoto thyroiditis, or Sjogren's syndrome in the salivary glands.
And the cool thing is that gastric MALT lymphoma can actually regress if you treat the underlying H. pylori.
Exactly. It's one of the few cancers where treating an infection can cure the lymphoma.
Now, let's step into the precursor lymphoblastic lymphomas.
These come from very immature lymphoid cells. Precursor T lymphoblastic lymphoma often presents as a mediastinal mass in adolescents or young adults. When the same cells spill into the blood, it becomes TALL.
And the B cell version?
Precursor B lymphoblastic lymphoma is less likely to form a mediastinal mass, but it can involve skin, bone, or lymph nodes. Both versions are very aggressive but highly responsive to therapy.
Anaplastic large cell lymphoma is another distinct T cell lymphoma, right?
Yes, the hallmark is ALK positivity from ALK gene rearrangements. The tumor cells are large, often with kidney shaped nuclei. Clinically, ALK positive tumors tend to occur in younger patients and have a much better prognosis than ALK negative ones.
And finally, the cutaneous T cell lymphomas.
Mycosis fungoides presents with skin patches, plaques, or tumors. The malignant T cells have cerebriform nuclei. When these cells circulate in the blood, causing generalized erythroderma, it becomes Sézary syndrome.
And these progress slowly, but can become quite debilitating. So that's our tour through the major non-Hodgkin lymphomas, indolent ones like follicular and MALT, aggressive ones like DLBCL and Burkitt, translocation-driven ones like mantle cell, the precursor lymphoblastic group, and the cutaneous T-cell lymphomas.
It's a big group, but once you break it down by cell type, behavior, and key translocations, the patterns really start to stick.
Alright, it's my favorite part. Let's test everyone's memory with a few mixed style MCQs from the non-Hodgkin group.
Let's do it!
Okay, the first question. Which lymphoma is associated with the T1418 translocation and overexpression of BCL2? A. Follicular lymphoma, B. Burkitt lymphoma, C. Mantle cell lymphoma, or D. DLBCL?
The answer is A. Follicular lymphoma.
Now on to the next one. Which lymphoma is characterized by a starry sky appearance? A. MALT lymphoma, B. Burkitt lymphoma, C. Mantle cell lymphoma, or D. SLL CLL?
Starry sky can only mean B. Burkitt lymphoma.
Ooh, we're on a roll today. Okay, next one. Which lymphoma is driven by cyclin D1 overexpression due to T1114? A. Mantle cell lymphoma, B. DLBCL, C. SLL CLL, or D. Mycosis fungoides?
T1114, that is definitely A. Mantle cell lymphoma.
Okay, let's see if you can catch this one. Which lymphoma is often associated with chronic inflammation such as H. pylori infection or autoimmune disease. A. Burkitt lymphoma. B. Malt lymphoma. C. DLBCL. Or D. ALK positive anaplastic large cell lymphoma.
Easy one. That would be B. Malt lymphoma.
And for the final question, brace yourselves. Which lymphoma often presents as a mediastinal mass in adolescents or young adults? A. Precursor T lymphoblastic lymphoma. B. Mantle cell lymphoma. C. Follicular lymphoma. Or D. Mycosis fungoides.
The answer is A. Precursor T lymphoblastic lymphoma.
Whoa, okay. We've covered a lot today. From the architecture of normal lymphoid tissue, to the patterns of reactive lymphadenitis, to specific infections, and finally, the malignant lymphomas. Let's wrap everything up with a clean recap.
Definitely. Starting from the beginning, understanding the basic structure of the lymph node really sets the stage. Cortex for B cells, pericortex for T cells, and medulla for macrophages. Every disease we talked about today essentially hijacks one of these compartments.
And with lymphadenopathy, we learned that age and clinical context matter a lot. Young patients tend to have benign causes, while older patients lean more towards malignant etiologies. Reactive patterns, whether follicular, paracortical, or sinus, depend on which immune cells are responding.
Then, we walked through the specific disorders like infectious mononucleosis, toxoplasmosis, cat scratch disease, Kikuchi's disease, and HIV. Each had its own fingerprint, whether it was atypical lymphocytes, posterior cervical nodes, papules after cat scratches, or necrosis without neutrophils.
After that, we compared all the Hodgkin lymphoma subtypes: nodular sclerosis with collagen bands, mixed cellularity with EBV association, lymphocyte rich with a great prognosis, lymphocyte depleted with the worst prognosis, and the popcorn cell type, nodular lymphocyte predominance with CD20 positivity.
And then the broader group, non-Hodgkin lymphomas, which had so much variety, from indolent ones like follicular and malt lymphomas to aggressive ones like DLBCL and Burkitt lymphoma. We also talked about mantle cell lymphoma with cyclin D1, the precursor lymphoblastic lymphomas, ALK positive anaplastic large cell lymphoma, and the cutaneous T cell lymphomas like mycosis fungoides and Sézary syndrome.
A huge range. But once you break them down by cell type, behavior, and key molecular signatures, the patterns really do stand out.
Exactly, and understanding these foundations makes hematopathology so much easier. It's just a matter of recognizing which part of the lymph node the disease is targeting.
And that brings us to the end of today's episode on lymph node disorders and lymphomas. And, well, the cute kittens we encountered along the way. We hope this helped connect the dots and made the topic feel a lot more manageable.
Whether you're studying for exams, reviewing for clinic, or just brushing up on the basics, understanding these patterns really changes how you see lymph nodes on physical exam or under the microscope.
Thank you so much for tuning in to PodBites. Make sure to join us next time for another time as we explore more of medicine's pathology stories. One bite, or shall I say, lymph node, at a time.
See you next episode!